Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. Now we're starting the Respiratory Pathology series for USMLE Step 1. This is the first episode for the Respiratory Pathology series, and we, just like we do for every episode in USMLE, we will discuss several conditions with pathophysiology, diagnostic strategies, and treatment. However, since this is a Step 1 episode, we will focus more on the mechanisms and the pathophysiology rather than on the treatment, algorithm, and the sequence. Let's start first with Rhino Sinusitis. And before we dive deep into this condition, let's break down the name itself. Rhino Sinusitis. Rhino means nose, right? So Rhino Sinusitis is a combination of rhinitis and sinusitis. In other words, this is an inflammation of both nasal mucosa and paranasal sinuses. The mechanism of rhinosinusitis, and especially sinusitis, is that there is obstruction of the sinus drainage into the nasal cavity. In other words, all of that mucus that is normally produced in the paranasal sinuses does not drain into the nasal cavity, and we know that whenever there is stasis of some kind of fluid, whether it's transudate or exudate, there is always a chance of bacterial overgrowth in that fluid. And this is what actually happens in that retained sinus fluid, which has the bacterial overgrowth. And bacterial overgrowth will cause infection, inflammation, and then we will call this condition the sinusitis. The clinical features of sinusitis are mostly the facial pain and the pressure sensation over the affected sinuses. Let's quickly brainstorm the paranasal sinuses, Zoosemmeliers. Do you guys remember the 4 different paranasal sinuses? I hear you. I hear you. Yes. Yes, exactly. Let's remind ourselves very quickly that we have frontal sinuses, maxillary sinuses, ethmoid, and sphenoid sinuses. Any of them can potentially become infected and inflamed. However, maxillary sinuses are the sinuses that are most commonly affected by the rhinosinusitis, and there is a very high yield mechanism behind this fact. We should know that the ostia, or the openings of the maxillary sinuses into the nasal cavity, are located supromedially relative to the maxillary sinus cavity. In other words, in order for the mucus produced by the maxillary sinus to drain into the nasal cavity, it needs to go up against the gravity, right? And so it means that there is a higher chance that the fluid and mucus produced in the maxillary sinus actually stays in the maxillary sinus, and then there will be bacterial overgrowth there. Before we continue talking about the causes of rhinosinusitis, let's briefly discuss the anatomy of the nasal cavity and the different anatomical relationships of the different meatus, specifically superior, middle, and inferior meatus. We know that nasal sinuses, sorry, not nasal sinuses, but the nasal cavity is divided into 2 parts by the nasal septum, which is mostly cartilage, and then we also have the turbinates. So turbinates are also called concha, and concha are these semicircular bony structures coming out from the lateral part of the nasal cavity, and it creates the turbulent flow of the air that we inhale through the nose. And the function of the turbinates is to humidify the air and to make it more turbulent so that the air just cleans up all of those paranasal sinuses and also the nasal cavity. We have superior concha, middle concha, and inferior concha on both sides, certainly. And then meatus, every single meatus is in a specific relationship anatomically to the concha. For example, superior meatus, which is the opening for several paranasal sinuses, is located below the superior concha. And that's the general rule of thumb for the anatomical location of concha and the meatus. The corresponding meatus is always located below the corresponding concha. So once again, superior meatus is below the superior concha, and we should know that superior meatus drains the sphenoid sinus. Also, it drains posterior ethmoid sinuses. Then we have middle meatus, which is below the middle concha, and middle meatus drains the largest number of the sinuses. So it drains maxillary, frontal, and anterior ethmoidal sinuses. And finally, we have inferior meatus, which is below the inferior turbinate or concha, and inferior meatus drains the nasal lacrimal duct. Nasal lacrimal duct is the duct which connects the nasal cavity to the lacrimal sac, which is on the medial side of the eyelid, and therefore this is how the lacrimal or tearing apparatus is connected to the nasal cavity. And this is why when the person cries, the nasal cavity also becomes wet, because all of those tears, they drain into the lacrimal sac. Then from the lacrimal sac they drain into the nasal lacrimal duct, and finally they drain into the nasal cavity. Okay, that was a side note of the nasal anatomy, and now let's get back to rhino sinusitis. The thing that we should know is that rhino sinusitis is mostly a viral infection, and the viruses that commonly cause the upper respiratory infection, for example, rhinovirus, which is the picornavirus, or adenovirus, can both cause the rhinosinusitis. But please don't think that only these two viruses can cause this condition. Literally any virus that can cause upper respiratory infection can also cause the rhinosinusitis. However, probably more dangerous is either primary bacterial rhinosinusitis or bacterial superinfection on the previous viral rhinosinusitis. We should also know the bacteria which can commonly cause the rhinosinusitis. And there is one caveat which I'd like to pay attention to. Previously, we knew that the most common bacterium causing bacterial rhinosinusitis was strep pneumo, and then we had H. influenza non-typable or non-encapsulated, and finally Moraxella catarrhalis. But now it's no longer true. The most common bacterial cause of rhinosinusitis now it's H. influenza, non-typable serotype. Then we have strep pneumo, and then we have Moraxella catarrhalis. The reason we are stressing the rhinosinusitis as a condition is that rhinosinusitis can be potentially related to many different complications, because the infection from the paranasal sinuses can spread into many different locations, including the orbits of the eye, cavernous sinus, and also the brain or meninges. And consequently, we will receive the different infections and inflammatory processes after this dissemination. What I mean here is that if infection, let's say from the frontal or maxillary sinusitis, spreads to the orbits, then we will have orbital cellulitis or post-septal cellulitis, which means cellulitis posterior to the eyelid septum, right, or orbital septum. And if the inflammation spreads into the cavernous sinus, we will get cavernous sinus syndrome, and we can have cranial neuropathies because cavernous sinus contains several cranial nerves, right? That's cranial nerve 3, 4, 5, 1, 5, 2, meaning first and second branches of the trigeminal nerve, and cranial nerve 6. And then if paranasal sinus infection spreads to the meninges, we will consequently get meningitis. If it spreads all the way to the brain, we can get either diffuse encephalitis, which literally means the inflammation of the brain, or we can get the brain abscess. And these are the potential complications. So if the question on the step 1 or any step on QMIND asks you what are the potential complications of the paranasal sinusitis, please always think about the orbits, cavernous sinuses, brain, and meninges. And this was discussion about rhinosinusitis. Now we will move on to the discussion of the epistaxis. Epistaxis is the same thing as nosebleed. And we should know that epistaxis or nosebleed most commonly occurs from the anterior part of the nostrils, and there is a specific capillary network in the anterior part of the nasal septum, which is called Kisselbach's plexus. And Kisselbach's plexus is the most common site from which the nosebleed originates. We should definitely know the different arteries which together comprise the Kisselbach's plexus. And I think the mnemonic that the first aid has for Kisselbach plexus components is amazing, because I use this mnemonic every time I want to recall the different arteries comprising this plexus. And the mnemonic sounds like this. Kisselbach drives his Lexus with his legs. And the word legs denotes the different arteries with its first letters. So L stands for superficial labial artery, which basically traverses the upper lip, and then it terminates at the nasal septum. Then we have anterior and posterior ethmoidal arteries, which come out from the ethmoid bone through the anterior and posterior ethmoidal foramina. We also have the greater palatine artery, which goes through the hard palate, and then we have Sphenopalatine Artery. And let me talk a little bit about the Sphenopalatine Artery. The Sphenopalatine Artery is the posterior branch of the Kisselbach's plexus, and it originates from the maxillary artery. There are several clinical correlations which are pretty high yield, so it's worth mentioning them. First of all, I know that it's not from the respiratory, guys, but do you guys remember which embryonic aortic arch gives rise to the maxillary artery? If you do remember, that's so cool. That's unbelievable. And so it's basically the first aortic arch which gives rise to the maxillary artery, and therefore it gives rise to all of the branches of the maxillary artery, including the Sphenopalatine Artery. And generally, nosebleed is not life-threatening unless the patient has some kind of coagulopathy, either platelet disorder or secondary hemostasis disorder. The nosebleed usually subsides and resolves on its own, and for this we should pinch our nostril and we should tilt our head forwards, not backwards. I know that many people, including myself, used to tilt the head backwards, but that's not the most efficient way of stopping the nosebleed. We should actually pinch the nostril and tilt the head forwards. I will not go into more details about stopping the nosebleed because that's more of a CK territory. So let's focus on the pathophysiology and the etiologies of the epistaxis. Well, the most common cause of the epistaxis is actually the digital trauma. In other words, to say it simply, the nose picking with the fingers is the most common cause of the epistaxis. There might be also a foreign body lodged in the nasal cavity, and that's usually common in toddlers who like to like to put the different things in their nose. At the same time, allergic rhinitis can result in epistaxis because allergic rhinitis results in hyperplasia and hypertrophy of the nasal mucosa with dilation of the vasculature, which makes the vasculature more prone to rupture and bleeding. And finally, there is one very peculiar cause of nosebleed, which is called nasal angiofibromas. Nasal angiofibromas are usually common in adolescent males, and yeah, this is it. So male, the male kid might also have some difficulty breathing with the nose because these nasal angiofibromas also obstruct the nasal cavity. Angiofibromas can be located in any other location in the body, and we know that when we have angiofibromas on the face, which is called adenoma sebaceum, but that's a misleading name, it's characteristic for tuberous sclerosis. However, nasal angiofibromas are not associated with tuberous sclerosis, and it's usually an isolated finding. So this was discussion about the epistaxis. Let's discuss the head and neck cancer next. Head and neck cancer is exactly what it sounds like. It's the cancer in the region of the head and neck. In most of the cases, head and neck cancer is usually squamous cell carcinoma. And this is the reason why it is abbreviated as HNSCC, or head and neck squamous cell carcinoma. The reason for this is that most of the mucosal surface in the region of the head and neck is covered by the stratified squamous non-keratinized epithelium. That's not true for all the areas in the head and neck, but most of the mucosal area is covered by this type of epithelium. There are several risk factors, knowing which is very high yield for step 1. The two most important risk factors are smoking and alcohol. Smoking is a much more important risk factor because there are more smokers than alcoholics, right? So what I'm saying is that epidemiologically speaking, people have more exposure to tobacco smoke than to alcohol. However, both of them can cause the squamous cell carcinoma anywhere starting from the mouth all the way down to the esophagus. There is one more interesting thing about smoking-induced head and neck cancer. It's not necessarily the cigarettes that cause the head and neck squamous cell carcinoma. Even the chewing tobacco, the tobacco that does not have this smoke, can cause squamous cell carcinoma. What I'm trying to say, zooassemblers, is that it's the contact of tobacco with the mucosal surface that causes squamous cell carcinoma. It's not necessarily the smoke of the cigarettes. The other causes of head and neck cancer include human papillomavirus 16, and we know that HPV 16 commonly causes oropharyngeal carcinoma. And here is one extremely high yield thing which I want to tell you. Although it's HPV 16 which causes oropharyngeal squamous cell carcinoma, the HPV serotypes which cause the vocal cord papillae are HPV 6 and 11. Yes, you haven't misheard it. HPV 6 and 11, exactly the ones which usually cause condylomata acuminatum, meaning the genital warts by the human papillomavirus. Okay, let's get back to the head and neck cancer. Another possible cause is Epstein-Barr virus. We know that EBV, or human herpes virus 4, is commonly associated with the nasopharyngeal carcinoma, especially in Asian individuals, and specifically males. As I remember, nasopharyngeal carcinoma is more prevalent in Asian males than in Asian females. And nasopharyngeal carcinoma can present with nasal obstruction, difficulty breathing with the nose, there might be epistaxis, discharge, and things like this. And even more importantly, since this cancer is in the nasopharynx, it can obstruct the eustachian tube. Zooassemblers, do you remember which cavity is drained by the eustachian tube? I hope you're telling me that this is middle ear cavity, or so-called tympanic cavity. And we also know that whenever there is obstruction of the hollow tube, there is a risk of bacterial overgrowth and infection proximal to that obstruction. In other words, if nasopharyngeal carcinoma obstructs the eustachian tube, there is a risk that the bacteria overgrow in the middle ear cavity, and we can get the acute otitis media. We can even get the otitis media with effusion, which is chronic type of the otitis media with medullary effusion, and sometimes we might end up with the hearing loss, mostly conductive hearing loss, which is caused by the fibrosis of mostly otosclerosis, meaning hardening, and the fibrosis of the malleus, incus, and the stapes. The last thing that I would like to tell you about the head and neck cancer is a very important concept called field cancerization. It's also called the field effect or field defect. Yeah, I know there are three names, the same concept, but it's worth knowing the three names. And the idea is that a very broad mucosal area or mucosal field is exposed to the same carcinogen, and therefore we might have multiple different tumors that arise independently of each other. Let's take an example. Let's say that we have a person who is a long-time smoker, and now we diagnose him with, let's say, oropharyngeal squamous cell carcinoma. And let's say that we excise the tumor because it was low-stage tumor localized to the mucosal area. And then several years later, the patient comes back with the same complaints, and we diagnose the squamous cell carcinoma now in the oral cavity rather than in the oropharynx. It means that the tobacco contaminated his mucosal area, including the mouth cavity, like oral cavity, oropharynx, and all the way down to the esophagus and so on, and therefore several different tumors can arise independently from each other. So recurrence is really common in the tumors, which are characterized by field cancerization. Let me tell you very briefly here that field cancerization is also very common in the urinary tract tumors, especially in urothelial carcinoma. Let me remind you that smoking is also a risk factor for urothelial carcinoma due to filtering of these polycyclic aromatic hydrocarbons through the glomeruli, and therefore when this contaminated urine bathes the whole collecting system, starting from the minor calyces all the way down to the urethra, the urothelial carcinoma can arise potentially anywhere. And this was discussion about head and neck cancer. Now we will move on to a DVT, or deep venous thrombosis. And deep venous thrombosis literally means the thrombus developed within the deep vein, mostly of the lower extremities. However, please keep in mind, zooassemblers, that DVT can absolutely arise in the deep veins of the upper extremities, which is called upper extremity DVT. However, it's less common compared to the lower extremity DVT, and here in the step 1 course we will focus on the lower extremity DVT. You can find out more about the upper extremity DVT in our CK course. Okay, let's get back to the DVT. Again, this is the blood clot within the deep veins, mostly of lower extremities, and then it has specific findings on the physical exam. Well, they're not super specific, however, they give us the idea or at least suspicion that the patient might have DVT. When there's a clot obstructing the deep vein of the lower extremity, the blood flow is impeded, right? So what I'm saying is that there is no outflow of the blood from the lower extremity, and that venous blood accumulates in the leg, and we know that the blood is red, so excessive blood will make the leg look red, right? At the same time, blood is warm, which means that excessive blood accumulation in the lower extremity will make the extremity warm. The patients with DVT also have the pain in the ipsilateral leg, meaning the leg affected with the DVT. How do we explain the pain? Okay, we have explained warmth, we have also explained the redness or erythema, but what about the pain? It's a little bit more complicated. However, there's nothing impossible, so it's not impossible to understand. And like, bear with me right now. Here's the thing: we know that microvasculature is composed of the arterial, capillary network, and the venule, and then we have the vein, right? When there is the obstruction in the deep vein of the lower extremity, the blood backs up in the venule, right? And then this pressure is transmitted back into the capillary network and then into the arterial. So there is a generalized impedance of the blood flow into the microvasculature. In other words, insufficient amount of oxygenated blood goes into the lower extremity through the arterial. And if there is less oxygenation of the extremity, it means that there will be less ATP production by the electron transport chain, so that the muscles of the leg will depend more on the glycolysis or anaerobic metabolism, the byproduct of which is the lactate. And we know that the accumulation of lactate causes the pain. And this is why patients with DVT can experience the pain. It's extremely high yield to know the Workhouse Triad, which is associated with an increased risk of DVT. Workhouse Triad is commonly remembered by the mnemonic SHE or SHE, because each letter in this mnemonic stands for three different conditions which predispose the patient to the DVT. S stands for stasis. Stasis means the relative immobility of the blood. In other words, when the patient's lower extremities don't move for a long time, then there is insufficient blood movement through the deep veins of the lower extremity. So there might be a little bit sluggish blood flow, which can predispose the patient to development of the DVT. And the stasis is usually associated with the post-operative rehabilitation, because most of the patients after some kind of surgery require so they are supine, right? They spend most of their time in bed, and when we are in bed, well, we don't move our extremities that much, which can cause stasis of the blood in our legs. At the same time, if the person is traveling via plane or via car on a very long distance, the relative immobility of the legs can also predispose her or him to the development of the DVT. The H in the Workhouse Triad stands for hypercoagulability. The patient can be hypercoagulable due to many different reasons. There might be a hereditary hypercoagulable state, the most common of which is factor V Leiden mutation. And let me remind you very briefly that this is the factor V which is resistant to cleavage by the activated protein C, right? Okay, let's go back to the DVT. The other causes, probably more common causes of hypercoagulability, are, let's say, oral contraceptive use, because we know that the OCPs commonly contain estrogen. And estrogen stimulates hepatic production of the coagulation factors, making the patient hypercoagulable. Pregnancy can also make the lady hypercoagulable, and the reason, the mechanism behind why pregnancy makes lady hypercoagulable is the same that we discussed for the OCPs. We know that the pregnancy is associated with persistently high levels of estrogen, right? And once again, estrogen stimulates hepatic production of the coag factors, which in itself predisposes the lady to the development of the DVT. And the final component of the Workhouse Triad is E, which stands for endothelial damage. Now, what can cause the endothelial damage? That can be the trauma to the large vessels of the body. For example, let's say that the patient is undergoing cardiac catheterization. And let's say that they insert the catheter from the femoral artery. We know that in order to reach the heart, all the way up from the femoral artery, we should traverse the whole aorta, right? And we might actually have the damage of the endothelium, which can predispose the vessel to thrombosis. I think that was that was a bad example because I was talking now about the arteries. However, the disease that we're discussing is deep venous thrombosis. But I hope that you got the point. So whenever there is the damage of the endothelium by anything, by any type of trauma, the exposed collagen underneath the endothelium is a stimulus for the adhesion and then aggregation of the platelets. Okay, now how do we diagnose the DVT? The test of choice here is the compression ultrasound with Doppler. This is the ultrasound study, and the Doppler mode also shows us the blood flow and the direction of the blood flow. And if we see non-compressibility of the vein with the Doppler, that suggests the DVT, because if the vein is not compressible by the Doppler, it means that there is this hard mass, i.e. thrombus, in the vein, which does not allow the compression of the vein by the ultrasound. However, D-dimer is a very important topic in terms of DVT and also pulmonary embolism, and we will not go into much detail about D-dimer here because the clinical utility of D-dimer is tested more on CK than on step 1, but let me still tell you one thing. D-dimer is a very non-specific laboratory investigation. In other words, D-dimer is elevated in any cause of hypercoagulable state or any cause of thrombotic disorder, almost in any cause. So what I'm saying is that whenever there is a thrombus in the body tries to break down that thrombus by the fibrin, and so not by the fibrin but by the plasmin, I'm sorry, and then one of the fibrin degradation products is the D-dimer. So elevated D-dimer simply means that there is thrombus somewhere which is getting degraded. However, it does not mean that it's the DVT that is getting degraded. D-dimer has a very high sensitivity for DVT, which means that it will almost not miss the cases of DVT. However, it has very low specificity, as we already mentioned. The treatment for DVT, once again, we will not focus here on the sequence of the treatment. That's a CK area. However, we should say that DVT caused by hypercoagulable state should be treated with anticoagulants. The most commonly used anticoagulant is heparin. We can give either unfractionated heparin, or we can also use the low molecular weight heparins like enoxaparin, dalteparin, also fraxiparin, for example. And heparin is used not only for the acute management of the patient, but also for the prophylaxis, meaning whenever the patient has a high risk of getting DVT, let's say that the patient is hospitalized or bedridden for quite a long time, let's say more than a week, or if the patient has undergone some kind of surgery which makes the patient intrinsically hypercoagulable, or let's say that the patient has COVID-19, right, which has also been shown to increase the hypercoagulable state. All of these patients need some kind of prophylaxis against the DVT and pulmonary embolism, and here we will use heparin. But we can also use the medications like NOACs, meaning like direct factor Xa inhibitors mostly, so apixaban and rivaroxaban and doxaban and things like this. And this is how we wrapped up the deep venous thrombosis. I think it will be very logical if we continue our discussion with pulmonary embolus. Pulmonary embolism is the obstruction of the pulmonary artery or one of its branches by an embolus. And the embolus itself is not the same thing as the thrombus. And Zoos Emuliers, I would really like to draw your attention to this concept. Thrombus is the accumulation and aggregation of the blood cells. So it might be mostly RBCs in the venous thrombus, plus the platelets and the cofactors, or mostly platelets in the arterial thrombus combined with the coac factors. That's the thrombus. And the thrombus can embolize. Embolus means the movable or moving mass in the circulation. However, the embolus can be composed of different things. For example, we can have thromboembolus. We can have fat embolus, air embolus, or bacterial embolus in case of the sepsis. In pregnant ladies, we can also have the amniotic fluid embolus, and in people with malignancies, we also can have tumor embolus. I hope that the difference between embolus and the thrombus is clear now for you. Okay, let's get back to the pulmonary embolus. The most common cause of the pulmonary embolus is actually thromboembolus. We have already discussed the DVT, and it's the thrombus produced in the deep veins of the lower extremities, let's say iliac vein or femoral vein or popliteal vein, which then embolizes into the pulmonary arteries, right? And we know that when we have pulmonary embolus, we have a VQ mismatch, which is called the dead space. In other words, there is the insufficient or absent perfusion to the particular segment or the lobe of the lung. However, that segment or lobe of the lung is still normally ventilated and normally aerated. And this is the dead space. And we should know that if we give supplemental oxygen to the patient who has a dead space, let's say the pulmonary embolus, the hypoxemia will correct. The idea is that the blood will be shunted from the obstructed vasculature into the vasculature that has the access to the ventilation. Therefore, we can actually increase the oxygenation of the blood by giving supplemental oxygen. And this is in contrast to the shunt, because whenever there is a shunt in the lungs or in the heart, giving the supplemental oxygen will not change the PaO2 significantly. Okay, the symptoms of the pulmonary embolus are mostly like sudden onset dyspnea. We might also have the pleuritic chest pain. Guys, do you remember what pleuritic chest pain means? I hope you do. Pleuritic chest pain is the chest pain which gets worse with inhalation or coughing. So whenever we increase the intrathoracic pressure, this is when pleuritic chest pain gets worse. Okay, the patient might also have tachypnea due to hypoxemia, also tachycardia, also caused by hypoxemia, and respiratory alkalosis, which is caused by hyperventilation and blowing off of that CO2. The thrombus, which gets lodged in the pulmonary arteries, can be of different sizes. If we have an extremely large thrombus, or the embolus comprised of the different material, we can actually get the settle embolus. Settle embolus is the embolus which gets lodged at the junction of the right and left pulmonary arteries, and it causes acute right ventricular strain, which is commonly followed by the electromechanical dissociation or pulseless electrical activity. Let's break down this word. Electromechanical dissociation. It means that the electrical and mechanical functions of the right ventricle are dissociated. In other words, right ventricle maintains the electrical function. In other words, there is the depolarization of the right ventricular myocardium. However, it loses its mechanical function. So it can no longer pump the blood into the pulmonary arteries because there is this large settle embolus obstructing both pulmonary arteries at the same time. So this is what electromechanical dissociation means, and it's the same as pulseless electrical activity. So we still have electrical activity on the ECG, which means that right ventricle and the whole myocardium generally depolarizes. However, there's no pulse, because if the settle embolus obstructs both pulmonary arteries, the left heart venous return is extremely low. It might be also zero, which will result in an instantaneous death. Okay, now what will we find on ECG? Here's the thing. The most common finding of pulmonary embolism on ECG is sinus tachycardia. I know that some of you were thinking of the S1Q3T3 abnormality, which means that we have deep S waves in the lead 1, not V1, but lead 1 in the standard or limb leads. We also have the deep Q waves in lead 3, and we have inverted T waves in lead 3. Although this abnormality indicates the right ventricular strain, it's not the most common ECG finding in case of the pulmonary embolus. It's very high yield for the step 1 to distinguish whether the pulmonary embolism is caused whether the pulmonary embolus occurred before death or after the death of the patient. The idea is that when the person dies, then the relative immobility of the blood causes diffuse coagulation of the blood. But how do we know if the thrombus lodged in the pulmonary arteries was formed before the death and possibly caused the death of the person, or it was produced after the death of the patient due to generalized hypercoagulability? The way we can differentiate this is by the lines of Zahn. The lines of Zahn are the alternating pink and the red colors in the microscopic finding of the thrombus. And the pink area in the lines of Zahn indicate the platelets and the fibrin, while the red area indicate the RBCs. And this order and the orderliness is characteristic for the pre-mortem thrombus. In other words, if the thrombus was formed before death, then we will see the lines of Zahn on the microscopic analysis of the thrombus. However, if the thrombus was formed after the death, then there will be no lines of Zahn. There will be no order by which the platelets and fibrin and the RBCs are placed inside the thrombus. Okay, we have mentioned in the beginning of this discussion that the embolus can be comprised of many, many different material. Let's talk about the fat embolus. In that case, the adipocytes and the fat basically go out from the bone marrow of the long bones, and then it gets lodged into the pulmonary vasculature. And it's very important to know the risk factors for the fat embolus or fat embolism syndrome. It might be the long bone fractures because, once again, in an adult patient, the bone marrow of the long bones becomes mostly the yellow bone marrow, which contains a lot of adipocytes, right? And those adipocytes can actually translocate from the bone marrow into the blood vessels if there is the long bone fracture. Liposuction can also cause dislocation of the adipocytes into the blood, and at the same time, very importantly, acute pancreatitis is a risk factor for fat embolism syndrome. The reason for this is that, let me remind you, there is peripancreatic fat around the pancreas, and in acute pancreatitis, we have enzymatic fat necrosis, which also causes saponification of this fat, right? And all of these fatty acids can actually go into the circulation, and they can cause the fat embolism syndrome. Let's move on to the air embolus. Air embolus is when the nitrogen bubbles precipitate in the patient's lungs and the pulmonary capillaries in the ascending divers, meaning when the patient dives deep into the sea or in other area with water, and then the patient rapidly ascends, this pressure change actually causes accumulation of the nitrogen bubbles within the pulmonary capillaries, and that can actually cause the air embolism, right? So it's also called the Caisson's disease or decompression sickness. And if the nitrogen bubbles lodge in the pulmonary capillaries, we call it the chokes because the patient mostly has the respiratory difficulty and tachypnea and hypoxemia. But at the same time, nitrogen bubbles can go all the way to the vasculature of the muscles and the bones, and in that case, the patient will develop the bone pain and the muscle pain, which is also called the bends, right? And at the same time, air embolus might be iatrogenic as well. For example, central line placement can introduce the air into the central veins, for example, into the internal jugular vein or superior vena cava, and that can also precipitate the nitrogen bubbles. And I'm sorry, I think I forgot to tell you the triad of the fat embolism syndrome that we discussed several minutes ago. Fat embolism syndrome is characterized by hypoxemia, neurological abnormalities, and petechial rash. Well, if those adipocytes get lodged in the pulmonary capillaries, yes, less blood will get oxygenated, and this is why we have hypoxemia. Hypoxemia in and of itself can cause the neurological abnormalities, and we also can have the petechial rash. However, the petechial rash is not a must. In other words, I have seen the cases of the patient who has no petechial rash, has only hypoxemia, neurological abnormalities, and the risk factor for fat embolism syndrome, and he or she still has fat embolism syndrome. So please don't look for all of these three findings. Even if we have only hypoxemia and the neurological abnormalities in the right context, we can still think that this is a fat embolism syndrome. And at the same time, I'd like to talk to you about the amniotic fluid embolus. The amniotic fluid embolus usually occurs, it might occur during the normal labor, it might also occur during the postpartum or during the obstetric emergencies like abruptio placentae, let's say. And this is when the amniotic fluid gets into the maternal circulation. We should mention the fact that amniotic fluid contains the fetal tissue factor, or fetal tissue thromboplastin, right? And the tissue thromboplastin of the fetus can actually combine with the maternal factor 7, and together they create the extrinsic 10ase, the enzyme that breaks down the factor 10, and it activates the coagulation cascade, resulting in disseminated intravascular coagulation. In other words, amniotic fluid embolus is one of the most dangerous emboli that we have discussed because it can cause DIC, and it has a very high mortality. However, fortunately, amniotic fluid embolus is quite rare. And this was our discussion about the pulmonary embolus. Now we will discuss the mediastinal pathologies, and we'll start by talking about the mediastinal masses. Before we do this, let's remind ourselves the different structures which are normally located in the mediastinum. We know that our heart is in the middle mediastinum, the thymus is located in the anterior mediastinum, and mostly it's antero-superior mediastinum, especially in the young children and the young patients in whom the thymus is still relatively large. We also have the lymph nodes in the mediastinum, for example, mediastinal lymph nodes, the hilar lymph nodes. Mediastinal lymph nodes drain the esophagus and trachea, while hilar lymph nodes drain the lungs. We also have the esophagus in the middle mediastinum initially, and then in the posterior mediastinum, and the aorta too. And aorta is mostly in the posterior mediastinum. However, the ascending aorta and aortic arch can be considered to be in the middle mediastinum, but what I would like you to remember is that descending aorta is completely in the posterior mediastinum. It is very high yield for the USMLE Step 1 to know which pathologies are located in which compartments of the mediastinum. Generally, we know that mediastinum is divided into superior and inferior parts along the sternal angle of Lewis, right? And we have like superior and inferior mediastinum, and each of these compartments is further subdivided into anterior, middle, and posterior mediastinum. Let me tell you that this last way of classifying the mediastinum is more important than superior and inferior mediastinum. Okay, let's first talk about what diseases can occur in the anterior mediastinum. And there is a very, very good mnemonic in the first aid reminding us of these pathologies. That's the 4 T's. The first T is thyroid disease, and in thyroid diseases we specifically mean substernal goiter. So the goiter can actually go down all the way to under the sternum, and that will be located in the anterior mediastinum. Second T is thymoma, because we know that once again thymus is in the anterior mediastinum, so thymoma itself, the tumor originating from this thymus, will also be located in the anterior mediastinum. As a side note, zooassembliers, do you remember what kind of paraneoplastic syndrome can be caused by thymoma or thymic hyperplasia? I agree. That's myasthenia gravis. Okay, let's get back to mediastinal masses. Teratoma can actually occur in the anterior mediastinum. And when the teratoma, this germ cell tumor, occurs in anterior mediastinum and generally in the midline positions, for example, in the pineal gland or in the midline retroperitoneum, it's called the extragonadal germ cell tumors. Let me tell you here that extragonadal germ cell tumors in the kids and the infants are usually located at the sacrum. We have the condition called sacrococcygeal teratoma, which is actually teratoma at the sacrum. Okay, and the fourth and final T is terrible lymphoma. Yes, lymphoma can also be in the anterior mediastinum. As for the middle mediastinum, the pathologies here are all about the esophagus and the bronchi. So we might have esophageal carcinoma, we might have the metastasis too, for example in the lymph nodes, and so on. Hiatal hernia can be seen in the middle mediastinum. And that makes sense because hiatal hernia is the part of the stomach, either the cardia or the fundus, penetrating via the esophageal hiatus at the level of T8, right? Sorry, not T8, but T10. I'm so sorry. Yeah. So what I'm saying is that stomach is continuous with esophagus. If esophageal pathologies are in the middle mediastinum, then hiatal hernias should also be in the middle mediastinum. And finally, the bronchogenic cysts are in the middle mediastinum because the main stem or primary bronchi themselves are located in the middle mediastinum. And the posterior mediastinal masses are easiest to remember. At least I think so, because they revolve around the neurogenic masses. So it might be neurogenic tumor like neurofibroma, it might be neuroblastoma, and at the same time we might have multiple myeloma in the posterior mediastinum, and that's also easy to remember because multiple myeloma is the tumor, the cancer, malignant tumor of the plasma cells, and that originates in the bone marrow. We know that the thoracic vertebra are located in the posterior mediastinum. So if multiple myeloma involves thoracic vertebrae, then it will be located in the posterior mediastinum. Now let's move on to the mediastinitis. Mediastinitis, as the name implies, is the inflammation of the mediastinum. It is commonly caused by cardiothoracic surgeries in less than 14 days after the surgery. So when there is opening of the sternum, the surgical manipulation can introduce the infection in the mediastinum, causing mediastinitis. At the same time, when there is the damage to the mediastinal structures, for example, when we have esophageal perforation due to Boerhaave syndrome, that can actually introduce the bacteria from the esophageal lumen into the mediastinum, causing mediastinitis. And finally, there might be a contiguous anatomic spread of the infection from the upper airways and also the oropharynx all the way down to the mediastinum. For example, when you have the retropharyngeal abscess behind the posterior pharyngeal wall and anterior to the alar fascia, that retropharyngeal abscess can actually spread all the way down to the mediastinum, and it can also cause mediastinitis. Even Ludwig's angina, which is the cellulitis of the sublingual mucosal tissue, can also spread into the mediastinitis. We might also have the chronic mediastinitis, which is associated with a lots of mediastinal fibrosis, which gives it another name, which is fibrosing mediastinitis. And the reason we have fibrosis is that there is proliferation of the fibroblasts, which then deposit the collagen in the mediastinum. And Chronic mediastinitis is very commonly caused by the Histoplasma capsulatum. Yes, I know that histoplasma is commonly associated with the, for example, pneumonia and TB-like symptoms, but it can also cause chronic mediastinitis. And the features for mediastinitis are the fever, there might be tachycardia due to involvement of the heart. We might also have leukocytosis, and generally systemic signs of the inflammation can be there. So we have come to an end of our today's discussion, and let's summarize everything that we have talked today. In today's episode, we have discussed Rhino Sinusitis, Epistaxis, head and neck cancer. We also talked very extensively about the deep venous thrombosis, its pathophysiology, clinical features, and the treatment. We continued talking about the pulmonary embolism, and finally, we wrapped up by discussing the mediastinal pathologies, including the Mediational Masses and acute mediastinitis. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, zoosevoliers, and see you on the next episode.